Thank you, Julia. Good morning, everybody, and welcome to our session on onco-anesthesia. And the topic I was given was, why should onco-anesthesia be a specialty on its own, and how do we take care of our patients in a manner that we can help outcomes with them? So I'm from Houston. For those who don't know much about Houston, Houston is famous for its space program, NASA, and it's also being the leader in energy sector. But we're also famous for the Texas Medical Center. So at the background, this is Houston downtown, and all this area north of the bayou is Texas Medical Center, and we have a South Campus as well. So Texas Medical Center is the largest medical complex in the world. It's a 1,300-acre campus. It has 61 institutions. And I'm proud and honored to work for MD Anderson, which is part of the Texas Medical Center. And if you can see the patient volumes here, within all institutions of Texas Medical Center, we do about 10 million patient visits, over 180,000 surgeries, over 25,000 deliveries, and we have the world's largest children's hospital, and of course, MD Anderson, where I work. And currently, it's expanding, and there are $3 billion worth of projects underway. So in terms of disclosure, I paid consultant to Medtronic, but nothing I discuss today will have any relevance to that. And while I go through these four main areas, I want to say that this is a tribute to our patients, caregivers who go along with the cancer care journey when their loved ones go through, but also a tribute to all our partners here. As Julia has said, we started this collaborative of major comprehensive cancer care centers from around the world. And it initially started as an interest group, and it's our goal to formalize this into a society. And I know there are some of you in the audience here who also work for comprehensive cancer care centers, and I apologize if your institution is not here. You're more than welcome to formally join us and be part of this movement. So as Julia had said, we have had good numbers on cancer stats from about 2008 published by WHO. This is open source, any one of you can see. And predominantly, cancer has been a disease of the Western world. And here you can see the incidence. Predominantly, the highest rates of cancer is in Australia, followed by New Zealand, North America, Western Europe, Northern Europe, and Southern Europe. And the numbers still are the same, even when you look at the latest figures from 2018. But projected out to 2030, globally, it's estimated that the incidence of cancer would increase by 50%, and the mortality would increase by 60%. And most of the increased incidence is going to be in the low and middle-income countries, and most of the mortality, again, is going to be in the low and middle-income countries. So I've told you the incidence spread of the various countries, but if you look at mortality from cancer, Mongolia is number 1, Zimbabwe is number 2, and Dominica is number 3. So really, we still have a lot of work to do. I'm not going to be sounding as an alarmist, but these are the numbers from the American Cancer Society, which have just been published in 2019. 1 in 3 of everybody sitting in this room today will hear the word, "You have cancer," in our lifetime. And that's inclusive of the disease in all sites. In 2015, in the US, cancer accounted for 25% of all deaths, and it's estimated that at the current rate, very soon it's going to be the #1 cause of death. But more importantly, other than the increased incidence of mortality, what cancer does is it increases the morbidity burden on all these patients. About a third of all cancer patients have limitations in their activities or abilities to perform activities of daily living. About 2/3 of cancer patients in their journey at some point develop from severe pain syndromes. About 25% of them suffer from depression. And as you can see, up to about half of all patients with cancer will have to change their work habits or work lifestyle. But all is not bad. There is a ray of some hope and sunshine, at least in the Western world. From the 90s, we have seen in the US a decrease in both the incidence and mortality, and in fact, there has been a 26% decrease in mortality. So the survivorship has increased. Currently, there are about 20 million survivors in the US. About 2/3 of survivors live for over 5 years. 15% live for over 20 years, and half of all survivors are over 70 years of age. So the cancer survivorship is becoming a big phenomena. And cancer survivors doesn't mean they're cured of cancer. We just don't have macroscopic disease or detectable disease. Cancer survivors, as I've told earlier, still have significant disease burden or symptom burden, and they have to be on a constant surveillance program. They may or may not have to be on repeated adjuvant therapies. So it's a journey they have to go along with. And in addition to that symptom burden, the cancer care as a whole, including survivorship, causes significant financial burden to the individual and the society. And here you can see it's just the US numbers. It's projected that by 2030, yearly in the US, we'll be spending $500 billion on cancer care. So this is an emerging tsunami that's coming our way. So you may think, okay, how does it matter to me as a perioperative clinician or as an anesthesiologist? In fact, in the 20 to the 70 age group, globally, 50% of all in-hospital admissions are related to cancer. And in the same age group, but predominantly in the 50 to the 70 age group, 50% of all those admissions for cancer require surgery. So your services, my services, our services are going to be needed in these patients. Moving forward, where is the need for us as perioperative clinicians to provide that care? It's going to be two patient populations, elderly joints and cancer. And that's the reason why we are here today. There is a need, and it's estimated that by 2030, about 45 million cancer operations will be performed worldwide. But more interestingly, at least in the Western world, about 70% of all patients with cancer will need our services, which is anesthesia, critical care, pain, at some point in their cancer care journey. And about 80% of this is delivered in a non-comprehensive, non-academic centers. So no matter where you practice, whether you're in a small regional hospital or a district hospital or an ambulatory setting or in an academic practice, you will be seeing patients with cancer. Now, I've shown that previous slide, at least in the Western world, where there's been a 20% decrease in mortality. And why do you think that is? It's because of multidisciplinary care. If you look at the surgical procedures that were invented, every surgical procedure that's being done now is invented at least 50 to 100 years ago. The only new invention in the surgical space is access. Laparoscopic, robotic, and minimally invasive surgery by whatever route in the last 35 years. So all these improvements in care, at least in the cancer patient population, and in transplant, as a very good other example, is because of multidisciplinary care. High volume centers where you have standardized practices, evidence-driven medicine, rigorous follow-up, and multidisciplinary expertise will lead to improved outcomes. And here is an example. The state of New York has had public reporting of patient outcomes for a long time, and it started with cardiac surgery. And here you can see that compared to all other institutions within the state of New York, if you have your cancer care in Memorial Sloan Kettering, we have our friends from Memorial Sloan here, your mortality and length of stay is much lower. But that's traditionally, we as anesthesiologists have not been part of that multidisciplinary care. Now we need to become part of that multidisciplinary care. And as Julia had outlined the reason why, cancer patients are different. As with any patient, we have to address their age-related and comorbid conditions. But in addition, cancer biology and staging, effects of cancer and cancer therapies on organ function and functional capacity, nutritional status, anemia, the surgical skill. All these improve or influence outcomes, most of which we don't have any control over. Furthermore, most of these procedures are neither elective nor emergent, but urgent. When a patient hears the word they have cancer and surgery is an option, they want the surgery done yesterday. You may not have the time to optimize patient's condition, but what you and I can do is to work on optimizing that patient if we have the time, designing perioperative care strategies to minimize oxygen debt and surgical stress, designing our strategies which are immunoprotective, minimizing preventable complications, and enhancing functional recovery. And when I say optimizing the surgical patient with cancer, it's looking at their nutritional status, their anemia, and their functional capacity. In other words, prehabilitation if we have the time. So this is the framework I rationalized for myself and I tried to explain to my colleagues and trainees. So the foundation of cancer care is understanding cancer biology and evaluating the effects of cancer therapies. Now I'm going to take a little time about cancer therapies. Cancer therapeutics is the fastest growing industry in healthcare. Even experts in the field have difficulty keeping up with all the new biologics, target-related therapies coming on board. And we have very little information on the intermediate and long-term effects of therapies. Most of these new biologics have effects on pretty much every organ system. So if you're taking care of a patient, and in your history you've elicited that the patient has had cancer or is on cancer therapies, please bear in mind that this patient may have affected cardiovascular system and disrupted endothelial function. Furthermore, because of the limitation in functional capacity and fatigue, they may not be able to give you a good objective assessment of their functional status. So keep that to the back of your mind. But the single most important thing I want you to take away in that is, if in the medical history you see a drug that you don't recognize or you don't know, and if the patient has had cancer, there's a good chance it is one of those newer cancer therapies. So please go and check and look at the side effect profile and what implications it's going to have. So the 4 pillars of improving cancer care is, number 1, cancer prevention and screening. Number 2, creating the body of knowledge and evidence that we need to call ourselves a specialty. Improving perioperative outcomes and educational programs. So first and foremost is education and screening. And why is that important, and why do we have a role to play? About 1/3 of all cancers are preventable. You as an anesthesiologist, when you're doing a preoperative evaluation of a patient, even for non-cancer surgery, we have a big role to play in addressing smoking cessation, weight management, and regular moderate exercise, sunscreens, vaccinations, and age and risk-appropriate cancer screening. This is just not for our patients. It's equally applicable for us and our loved ones. Because, again, remember, 1 in 3 of all of us will hear the word you have cancer, and 1/3 of cancers are preventable. So let me talk about vaccinations. Particularly for adolescents and children, HPV vaccination is very important to prevent head and neck cancers, cervical cancers, and anal cancers. It's got nothing to do with sexual preference or practices. The second thing of age and risk-appropriate cancer screening. Please examine yourself or your adolescents or children for glands in the neck, in the axilla, in the inguinal region on a regular basis. If you're in the 20, 30, and 40-year age group, testicular examination is very important to prevent testicular cancers or identify it early. For both men and women, it's very important to do self-screen of your breasts. And if you're over age 50 and haven't had a colon screening, you better get it done as soon as you can. And the same applies to every patient you see in the preoperative clinic. if you want to help them minimize that risk for cancer. Now, about weight management. Every 5 kilo gain in weight increases the incident rate ratio by 3%. So, say for example, you have a 15 kilo weight gain. Just that by itself increases our risk for cancer by 15%. Right now, it's estimated that 45% of all cancers are weight-related. And this is all the more relevant in women. Second, creating that body of specialized knowledge. With the experts from our collaborative group and others working in the field, we've now realized that cancer cells express mu-opioid receptors, voltage-gated sodium channels, GABA receptors, and they also are influenced by COX-2 and beta-adrenergic signaling. We exactly don't know yet how modifying these ligand receptor interactions or modulating those interactions will have a long-term effect. But my colleagues are going to discuss that in the next 3 talks. But more importantly, we are having a better understanding of the perioperative stress and its influence and how it can influence local, regional, and distant metastases. So that's the definition of a medical specialty. It's us together, a group of individuals coming together to understand the implications of the biology and see if we can improve patient outcomes. So these are the areas where our collaborative group and others are working on. I'm not going into the details, but what we also need to look to the future is the pharmacogenomics and how that can better help us understand anesthetic options in cancer surgery, and how do we make sure that we expand this beyond the intraoperative care to the postoperative period and ICU care as well. So while we wait to have evidence of all this work that's being done globally, what you and I can do today to improve patient outcomes is to work on minimizing symptom burden, minimizing preventable complications, and enhancing functional recovery. And the reason that's important in patients with cancer is, unlike a patient who's had a hip surgery, once they are discharged from the hospital, they're done. Our Uber driver who driven me from the airport said he had his hip surgery 3 months ago and he feels 20 years younger. No cancer patient will ever tell you that, once they've had their cancer therapies or surgery, that they feel 20 years younger. In fact, it's the opposite. They say they feel 20 years older. So the cancer patient, once they have their surgery, and here's an example for triple-negative breast cancer, they are in a surveillance program, they have adjuvant therapies, they constantly are restaged, and unfortunately, a third of all our patients with cancer, after their initial intervention, either get a recurrence or a second cancer. So they're constantly in this phase of surveillance and therapy mode. So it's very important for us to prolong that recurrence-free survival, that our patients, after surgery, go and get back their adjuvant therapies. So we have to do everything we can to get them back on track so they can get to their adjuvant therapies. Now, what are the reasons that the patients are prevented or limited from getting their adjuvant therapies in a timely manner? The 2 most important things are inadequate recovery or postoperative complications. So it's been well described in multiple patient populations that postoperative complications delay adjuvant therapies and negatively influence outcomes. So you and I have a role to play to minimize those preventable complications and make sure our patients are back on track. Then the question is, does any of this help? Do enhanced recovery programs help our patient get back to their adjuvant therapies? And we've shown this with patients with colorectal cancers who have hepatic mets and when they've had hepatectomy, compared to the baseline group, who 87% of all who had adjuvant therapies at about 34 days. In the enhanced recovery group, 95% of all were able to have adjuvant therapies in 22 days. So we were able to shrink that by 10-day period. Now, would this make a significant difference? It does. We just submitted our paper for review. We have 700 patients on enhanced recovery programs, and it does improve survival. So the second patient population is our thoracic group. similar to ours, thoracic patient population with enhanced recovery. They were able to show decreased complications. And here, again, an increased number of patients able to complete adjuvant therapies. Ollie Lundquist group have shown that colorectal patients, when they adhere to all the elements of enhanced recovery, there is an improvement in the 5-year survival. So I'm just going to take one more minute on the fourth pillar, which is developing educational programs. So I'm so proud of our global collaborative and what we were able to achieve in the last 7 years. We were able to bring researchers from basic science, translational, and clinical on work on not only the research, but also the educational programs to directly improve patient outcomes. So we started this first meeting in Houston in 2012. Since then, we've had meetings in every continent except Arctic and Antarctica. The meeting for 2019 will be in Shanghai, China. 2020 is going to be in New Delhi in April, and at Memorial Sloan Kettering 2 days prior to PGA in New York City. 2021 in London, and we're just talking to Bernhard probably in Singapore, and 2022 back to Houston for our 10th anniversary. Our group is also very active in publishing manuscripts. We are also working to bring out a new textbook on onco-anesthesia. In India, in August of this year, the Indian Society just formed their Society for Onco-Anesthesia and Perioperative Cancer Care. So friends, the time has come. It's because of the epidemiology, the need for us, how we can influence or prevent those cancer risk in 30% of the patients, how we can help improve patient outcomes by minimizing symptom burden, enhancing functional recovery, till we get data on particular anesthetic strategies and their perioperative outcomes. So I want to leave by this modified quote from Theodore Roosevelt. Take the lead now, if not us, who? If not now, when? And if not here, where? Thank you very much.